Hello, and thanks very much for joining us today for the RCGP Bright Ideas Masterclass, focusing on the cancer map. So what is Bright Ideas? It's an award by the RCGP to recognise and celebrate fresh approaches to practice at primary care. So I'm Dr. Steph Coughlin, and I'm Clinical Lead for Innovation here at the RCGP.
I'm Ben Noble. I'm a GP, and I'm one of the cancer leads at the East Midlands Cancer Alliance.
Okay.
Is that working?
Okay, so that's us. So what are we going to be covering today? We're going to be talking about how to use the cancer maps and how we can use these to help us identify patients who present with potential cancer symptoms, and how Ben went on to develop and implement the cancer maps and what have his experiences been from doing this. And then we're also going to consider how to use the cancer map style approach in different clinical settings. So here's what we're going to be covering today, thinking about what was the problem, where did it come from, what was the bright idea, and then what impact did it have? And most importantly for you watching, what are the next steps? And how can this be transferred in your day-to-day practice? Once we've done this, we'll have some time for questions and answers at the end. So please do use the messaging service so that you can submit the questions. Okay, so Ben, where did cancer maps come from?
Well, when the NG12 guidelines came out, I naturally mind map everything I get that I need to summarise. I've done that since I've been at medical school. I took my lecture notes in mind map form. And as a cancer lead, the NG12 guidelines were very important to me, and it was important that we got awareness of them out there. So when I summarised them, I mind mapped them, and it struck me when I was doing it that they lent themselves very well to that way of thinking, that flowchart way of thinking. And I thought, well, I wonder if I could get this out to the masses. Normally, mind maps are quite personal. You put your own little diagrams on so that you can remember them in your mind. So one of the problems I had was, if I'm going to make this accessible to everyone, how can I make it generic, if you like? How can I make it followable? And I have a good friend and colleague, Pavan Randev, who helped me with this. He said, well, could you not put it on a computer to start with? So the next thing I did was I found a piece of software called iMindMap, and I transferred what I'd done in freehand onto that. And I showed my wife, Hannah, who's also a GP, and said, do you think it's useful? And she said, well, yeah, but some of these symptoms are really difficult to know about. They're all new. How am I even to know they're there? If I see a patient with those, how am I even to know to look at the maps? So that's when I had the idea about the search function, and we'll show everyone that later, whereby we put the list of all the signs and symptoms in these maps. You can click on them, and they'll flash red where they occur on the guidelines. So that's how it came about. It came from just me drawing them in freehand.
And were there any challenges or barriers at the start?
Yeah, well, it was, as I said, really, it was trying to make it relevant to everyone. And I wanted to produce something that people could pick up and run with immediately. I didn't want people to have to log into something, to have to follow some lectures first before they could have access to it. I wanted to plonk it on GPs' desktops so that it was something they could use there and then with patients in front of them. That was the most important thing.
Great. So can you tell us now more about the cancer maps? What exactly are they?
They're in one context, they're a decision support tool. They're unintrusive. They're there to use if you want them. I categorize the uses into 4 main areas. You can either use the search function to look up signs and symptoms of your patients there and then during consultation. You can use them as a quick reference guide to look up signs and symptoms and whether you need to be referring or not. You can use them in education with your medical students or your junior doctors. And you can use them with patients. I think that's a really important way of using them. I do that a lot. I show patients these maps, and I find them really useful for safety netting and for reassurance as well. I get patients coming and saying, I'm worried these symptoms might be cancer related. And so I can show them maps and say, well, look, for that particular cancer you're worried about, these are the things we look for. So that not only reassures them, but it gives them some safety netting advice as well that they'll remember.
And what did you need to develop the cancer maps? So at the start, what did you need, and what support did you have?
I suppose the main need at the start was time. You know, I put many hours into this, and it became a bit of a labour of love. And when I started, I thought, well, there are certain bits of this I can't do from an IT point of view. So I was very lucky at the time. My dad, who's been in computers all his life, had retired, and so I put these to him. I said, well, could we do this search function? So if I stick all these signs and symptoms on these maps, could we do it somehow so that if someone clicked on those signs and symptoms, it would flash somewhere on these? And he was brilliant. So he got straight into it. He also spent hours, and I think the ability to work together was what really drew me to it. I didn't mind spending all those hours because I was working with my dad. It was magic. So time was the biggest barrier, I think. And then once we'd produced them, it was accessibility, how we were going to get them out there. Yeah. Because to start with, it came as an application. And we know what NHS firewalls are like. You just couldn't get that application past them. So one of the big barriers was getting it web enabled. And so again, my dad came in on that. He's never done anything like it before, but he got a book on how to use how to web enable software. And he learned from scratch, and he put it all on.
So you mentioned your wife, and you talked about, as a frontline GP, the complexities of navigating symptoms. Yeah. How else do you think this is useful for GPs?
I think it's useful because it's immediate. It's not something you've got to look up. It's there in front of you. So I have two screens when I'm practicing, and I have the maps open on one of those screens. I have patient notes on another one. And so if a patient comes in, especially with symptoms like weight loss, and you know weight loss is going to take you down a number of cancer pathways, the first thing I'll do is click weight loss on my maps, and then I'll take the rest of the history and I'll start clicking as I'm going along. And you can just have a quick look over and think, well, do I need to be asking about that, and that? And so it helps you guide a consultation. I think that's really important, because other tools available really require you to concentrate on them or open a book or whatever. And so it just makes a lot of information very accessible immediately.
So clearly you and your dad both, as you said, a labour of love, put a lot of time and effort into this. How did you then go on to test and make sure it was fit for purpose? How did you involve others?
To start with, it was colleagues. So my partners who I work with, I gave it to them and said, well, what do you think? And the feedback initially was great. I gave it to my colleagues in the Cancer Alliance, non-clinical as well as clinical. And again, the feedback was really positive. The non-clinical staff at the Cancer Alliance, East Midlands Cancer Alliance, felt that it was quite easy to follow from their point of view as well. And then I thought, well, if this is really going to get out there, not only do I need to have it endorsed by NICE, I'm going to need to pilot it as well. So that was the next step beyond sort of informally showing my colleagues. And
talk us through more about getting endorsement.
That was quite a long process. So I applied to NICE. I had to fill in this long form, and it was a bit like when I did my PhD thesis. It kept my answers to their questions were never quite enough, and I felt sorry for them because I had to check every single symptom box and every combination. But they were really helpful. The feedback I got all along was excellent. And eventually, with a lot of turn and fro, we got to a point where they were happy that the maps reflected everything in their guidance, and I was happy that it was still simple and easy to follow.
And for our viewers today, is there any advice on, looking back on the process you went through with NICE? Is there anything you would have done differently?
No, I don't think so. I think it was really, they were very helpful all along, and they were keen for this to get their endorsement. It was just having it just so for them, and there were certain bits the wording wasn't quite right for them, and so not really. No, it was just listening to their feedback and implementing it, but in a way that wasn't going to spoil the look of the maps.
Okay, that's really helpful to hear. Now we're going to move on to a demonstration of the maps themselves. Okay.
An interactive reference tool for the NICE NG12 guidelines. My name is Ben Noble, and I have devised these maps to make the guidelines more accessible to health professionals, as well as providing a visual aid for patients for the purposes of safety netting and reassurance. This tool summarizes the guidance in 3 maps, and I will
use map 1 to give a brief description of how it works, though I hope you will find it intuitive in the main. Essentially, we have advice divided in an organ-specific manner. This map summarizes laryngeal, oral, upper GI, lower GI, and lung cancers. The advice suggested by NICE to the health professional is on the purple branches just after the organs. Also, the full NICE guidance can be accessed by clicking this button. If we take lung cancer as an example, when would we order an urgent chest X-ray? This branch tells us we should consider an urgent chest X-ray for patients over 40 who have never smoked, but there are conditions attached. They must have at least 2 of these symptoms: weight loss, fatigue, cough, shortness of breath, chest pain, or appetite loss. Incidentally, it is assumed that the symptoms throughout the guidelines are unexplained. So for patients over 40 who have never smoked and have 2 of these symptoms, the clinician is advised to consider an urgent chest X-ray. This branch tells us that patients over 40 who have ever smoked or been exposed to asbestos only need have 1 of these unexplained symptoms. We have another branch here for patients over 40, regardless of smoking, with a different set of signs and symptoms, and they must have at least 1 of these to qualify for an urgent chest X-ray. Another feature of the maps is you can click on the purple branches in order to see the relevant NICE guidance in text form. Click outside the box to make it disappear. Perhaps the most important feature of the maps is the search function, which can be used during consultations. At the top of the screen, it's possible to select age and gender as part of a patient search. On the side of the screen, we see a list of signs and symptoms which appear in the NICE guidance. Select any one of these and they will flash red on the particular part of the map where they appear. For example, if we select a female patient, 45 years old, with chest pain, fatigue, and weight loss, we can see a number of flashing symptoms on the maps. The actual number of hits for these symptoms is displayed in the center of each map. Here, we can see that the combination of symptoms selected draws us to map 1. Click here to zoom on this map, and we can see that we are drawn to lung cancer, and an urgent chest X-ray is suggested in the guidance. Zoom out, and we can also see that other cancers should be considered with this group of symptoms. Map 2 demonstrates that the NICE guidance suggests the possibility of ovarian cancer for this patient, and a CA125 blood test is advised. Let's look at another example. If we consider a 56-year-old gentleman with COPD and hypertension and a history of dyspepsia, he has his annual blood tests which show raised platelets or thrombocytosis. Map 1 has 6 hits, so let's take a closer look. Firstly, unexplained thrombocytosis has been shown to be linked to a number of cancers, and for this patient, lung cancer is a possibility, and an urgent chest X-ray is suggested in the guidance. Then, if we look across at upper GI, we can see that because of his age, dyspepsia, and thrombocytosis, he should be considered for an endoscopy. It's important to point out that he wouldn't normally be considered for an urgent endoscopy because he doesn't have the qualifying weight loss shown in the preceding branch. Finally, it's also worth pointing out that some symptoms have been grouped, and it's left to the clinician to interpret the results demonstrated on the maps. For example, hematuria includes both visible and non-visible types. Also, urinary symptoms includes dysuria, urgency, frequency, and lower urinary tract symptoms. The cancer maps have been used by clinicians not only as a reference tool, but also with patients to aid safety netting and as a visual reassurance aid. They can also be effectively used as an educational tool for students and junior clinicians. I'm always grateful for feedback and can be contacted at the email address here.
Okay. So those are the basics of how to use them. So you can see that it's pretty easy to use during consultations with patients in front of you. I wanted to just bring a couple of case studies to this webinar to show how the guidance is not always intuitive to the organs. This is partly because these are the first guidelines to use primary care evidence, but also because the positive predictive value for cancer has been reduced for these guidelines from 5% to 3%. So we're bringing in new symptoms for different cancers. So this case study is a 52-year-old lady who has a couple of episodes of visible hematuria. Now, naturally, she is referred on a cancer referral 2-week wait to urology. She has a ultrasound of her renal tract and a cystoscopy, but nothing abnormal is found. We'll say she's got a bit of hypertension, and in 3 months' time, she has her chronic disease bloods, which show that her HbA1c is raised. She's given some dietary advice, and eventually goes on to have some metformin. 7 months after this, she presents with a postmenopausal bleed. She's referred, and it's found she has metastatic endometrial cancer. So anyone using the maps would have found that the raised blood sugar, the raised HbA1c, in conjunction with visible hematuria, would have led the clinician to consider an ultrasound of her endometrium. So that would have flashed red on map 2. So we might have been able to diagnose that one 7 months earlier than was here. If we move on to the next case study, this is quite a simple one, but one of the hardest cancers to diagnose and one of the poorest performers is lung cancer. This chap's 44-year-old, he's an ex-smoker, and he hardly ever comes to the GP surgery. And I think, that tends to put you on edge a little bit to start with when they come in. He just comes in because he's tired. It's been a couple of months now, and he's falling asleep in the afternoons. You don't really find anything much on the rest of the history. Examination is fine. So we give him some lifestyle advice. So he goes away, but he comes back 9 months later with a 4-week history of a cough, and he's lost his appetite. And you send him for a chest X-ray because of the cough, and it shows he's got shadowing on the right side of his lung. This is important because there are some really innocuous symptoms in NG12, one of them being fatigue. And anyone using the maps would have seen that someone over 40 who's a smoker or an ex-smoker or been exposed to asbestos, who has just some tiredness, would normally qualify for a chest X-ray. So we might have been able to diagnose that one 9 months earlier.
So what we're really interested in about now is what impact has it had? How have you evaluated it? What results have you collated? And what's been the response from colleagues?
Well, as I mentioned before, the informal response was great. what we did to formally evaluate this was recruit some GPs to use the cancer maps during their consultations, during their normal practice. They were asked each time they used it to feedback. There was a link for them to feedback on Doodle, and we collected the information, as we can see. So the first thing they answered was why they'd used the tool, and this was collected over a 3-month period. And we found that most uses were for the clinical setting. So that we found that I think that's 49%, the light blue color at the bottom, was to use the search function that we saw in the tutorial earlier. The next color shade down blue is the quick reference guide. So they're just to look up maybe an age range on NG12. The darker blue, it was an educational aid. I think we're 13% on that to use to teach, and then the grey is to use with patients. And I will say the using with patients, we did find during the pilot that it was underused with patients and maybe underappreciated. I probably could have done some teaching around the time, maybe done some YouTube videos of how I use it to give an example of how you could use it. But we did find with the pilot that it was underused in that area. But as I said earlier, my feedback from patients has been 100% positive when I've used it.
Yeah, that was what I was going to ask. Yeah. Is that in your day-to-day practice, you've had a good response?
Absolutely, every single time, because people respond better to pictures, to things they see rather than things they hear. We know that people remember about a third of what we tell them in consultations, but they'll remember far more of what they see. Next question, for each use of the maps, this was, did you learn something new or did you consolidate existing knowledge? Really encouraging was we found about a third of every single use of the maps resulted in new knowledge for GPs. And that brings us back to the case studies we did earlier. Some of those guidelines are really difficult, and we're dealing with complex symptoms, and GPs are brilliant with that. But some of these are new symptoms, and if you don't know them, you don't know them. So that new knowledge was really encouraging to see.
And do you think the differences with the new guidelines, do you think that's where some of the knowledge has come from, the sort of appreciation of gaining more knowledge has come from?
Absolutely, yeah. So bringing down the positive predictive value to 3% from 5% has brought in these new strange vague symptoms, which previously we haven't even experienced, GPs weren't aware of. And so that's why we're seeing this new knowledge, I think.
Just go back one. Okay.
So we got some feedback on whether people liked it or not. We got overwhelmingly they would use it again in preference to other summaries, and the other summaries are mainly hard copies of text-driven summaries that you would have to look down to and take your gaze away from the patient, whereas I think the maps work because they're on the screen in front of you.
Well, that's incredibly positive feedback, with over 90% saying that yes, they would definitely use it. Use it all again.
So these are the next couple of questions were asked at the end of the pilot, and we can see that people overwhelmingly found it useful as a reference guide, as a decision support tool. Less useful sharing with patients, as I mentioned earlier, only 42% found it useful for that. But again, I think unless it's pointed out how you could use it, not everyone's going to explore that. And then great to see that it was handy as an educational aid as well, and I've used it in tutorials and in presentations as well.
I think that was just the sort of thing that was coming to my mind, and actually with our GP registrars and GP trainees, actually how this sort of resource could be used to help simplify what can be quite a difficult guideline to navigate.
Absolutely, and overwhelmingly the most positive feedback I get is from the younger GPs and from junior doctors as well, who are used to using technology. We found 88% increased their knowledge of the cancer guidelines just from using the maps day to day. They overwhelmingly felt more confident making referrals, and that came out through the free text feedback I got as well. Felt more confident when talking to patients about the guidelines. And probably the most encouraging feedback was 53% made referrals they otherwise wouldn't have. And we know those referrals they made, they wouldn't have otherwise, were based on NG12. So they were right referrals. The pilot wasn't involved enough to get feedback on whether anyone diagnosed cancer that they otherwise wouldn't have. But I would like to think they did with those numbers. And then we see 97% would recommend the tool to other clinicians. And this is some free text feedback we collected. This is just a selection of it. Again, really positive. And that one on about the foundation training. I'm a foundation doctor tutor as well, and I use this with my junior doctors.
I suppose thinking about the conclusion, it's clear that the cancer maps have been effective and a really popular interactive tool with the GPs that you piloted it with. And actually the frequency of use demonstrates the need for awareness and education around the change in the guidelines and how they can be used effectively. And I can see that users overwhelmingly felt their knowledge had increased. And as you talked about, that 53% who'd made referrals that they wouldn't have otherwise, that's incredibly powerful. Yeah. And I suppose thinking about how the mind mapping approach and the mind mapping tool might have further uses. Have you thought about that?
Yeah, absolutely. It would work in all areas of medicine, quite frankly. And I know that because I mind map everything I learn. I've been asked to put together some maps for respiratory, for asthma, COPD, for diabetes, which I've done, but then the funding has fallen through and we haven't followed through on it. But I know it works, and there are various innovations you could put with each of those areas. Maybe the search function wouldn't be relevant for diabetes or for asthma, but you could put innovations such as spirometry guidance and things like that.
So I guess as we move on, two things I think would be helpful to think about. First is, for your Bright Idea, the cancer maps, are there plans for wider rollout? And then the second thing to think about would be next steps, transferability. How can those watching really implement this themselves? Mm-hmm. So let's talk about the Bright Idea and any plans for wider rollout first.
The maps are available on Gateway C's website. For those who haven't heard of Gateway C, it's an excellent educational module. They're online and they are available to all healthcare professionals. And they supply a number of modules, teaching modules on cancer diagnosis, earlier diagnosis. They're brilliant. Go and have a look at one after this webinar. The maps are on their website. And we're going to be looking to maybe make them look a bit nicer. They still look like some chump did them in his kitchen at home, which is basically what happened. So we're going to make them maybe look a bit more professional, but keep them simple. Because I think the fact that they're simple makes them work.
And I imagine the simplicity of them is one of the reasons that they were so successful.
Absolutely, yeah. You're not drawn away from the primary use of them.
Because we don't want to replace a complex guideline with a complex mind map.
Indeed.
And that's really where the power is in this. So. And then thinking about what would your takeaway messages be to those watching on things that they can do? You mentioned around educating for how you could use it with patients, mm-hmm. As one of the things. What would your advice be to those watching on how they can do this themselves?
Well, I think hopefully you've seen from the tutorial and from the case studies we've talked about how you can use them during consultations with patients in a clinical setting. For patients, it depends on the patient at the time. You kind of need them to give you a cue that they are concerned about cancer, or bring it up yourself. And if they are, it just gives you that opportunity to say, well, look, this is what I look for. These are the symptoms I look for that. This is best practice. And so it just gives you that opportunity to do that. And it gives them a visual aid whereby they can take that home. And it's possible to print these out as well, actually. One of the next steps it's worth mentioning is I'm going to do a patient version of these. Okay. So we'll take a bit of the jargon out, make it very easy to use. I know a lot of GPs will be thinking, oh God, we're going to have a load of patients descending on me worried that they've got some innocuous symptoms that aren't cancer related. We'll do it very carefully. And I'm taking feedback from patients and colleagues as I go along. And I think if patients can use it, because we to diagnose cancer earlier, we need health professionals to be on the board, but we need patients to be on the board as well. So if patients can start using things like this, gives them a printout, they can take that to their GP and say, well, look, I was a bit worried about cancer because of this. Look, that printout will give the professional link to the professional version of the maps, and they can consolidate their learning via those if they need to.
And have you got any other top tips for those watching on how to implement cancer maps where they are?
Top tips, just use them, practice using them. I'm always flattered when my colleague, I've got a colleague, one of the partners at work, tells me it's the first thing he brings up on his screen in the morning when he comes and logs in. And he's an excellent clinician. And I know that he's used these and he's diagnosed a cancer earlier as well. He had a gentleman who had thrombocytosis and nothing else. We know thrombocytosis is a risk factor for the leg OC cancers. So leg OC stands for lung, endometrial, gastric, esophageal, and colorectal cancers. And on further questioning, further down the road, he diagnosed a lung cancer in that chap. So it's just use them, and when you use them, you'll know, you will learn how you want to use them in future.
I know one of the next steps that you put together is around some infographics, and we'll bring up one of these now onto the slides. Can you talk us through these?
Yeah, I'm aware that there is no one-size-fits-all for learning. And I know that some people just won't get on with the maps and that way of thinking. These are a different way of thinking. These are pictorial examples of how you can think about NG12. And hopefully they dovetail quite nicely with what we've done with the maps. So what we've done here is just divided the branches, if you can imagine the branches of the maps. And we've transferred those into these pictures here. That we're looking to create a series of posters, maybe some mouse mats. Again, we're going to put a link to these on Gateway C. I've got a colleague, Nicola Humberston, who works for a consultancy company who's helping me with the posters. And
can you explain what mouse maps are?
Mouse mats.
Mouse mats. Oh,
yes.
Yeah. Can you explain what they
are?
Mouse mat. People watching might not know what that is.
So a mouse mat is just something that allows you to use your mouse when you're tracking around your screen. Okay. Yeah, it's just something you're going to look at over and over.
And so those are going to be put onto those infographics onto the mouse mats.
Yeah,
as well. Yeah. Okay, so people can see it when they're all.
We're in the process of doing that. I've just done final tweaks on these. So yeah.
And what feedback have you had on the infographics so far?
Entirely positive. I've not formally evaluated them yet, but so far so good. I mean, I've shown them to a lot of GPs, and there have been a few who have preferred these to the maps. I will say they're different. I mean, they're very organ-based, whereas the maps are symptom-based. So it kind of depends how you think about cancer symptoms.
So before we go move on to the question and answer session, just to say that we will be circulating the slides to all those watching today, and as well as all the links to the resources that Ben and I have been discussing. So please, that information will follow shortly. So please do, if you've got any questions, send them through on the messaging service, and we can put those to Ben as we continue the webinar. So to kick off, I've got a couple of questions here. We talked a little bit earlier about the change in the NG12 guidelines. Why do you think they're so different to previous ones?
They've taken in a lot of new evidence. They're primary care based rather than secondary care. So they've taken in new evidence that previously hasn't been used. As I mentioned before, the positive predictive value for cancer has been reduced from 5% to 3%. And we're now thinking in more of a symptom specific way rather than in organs. So we're looking at groups of symptoms which might confer a risk of cancer now more so than we previously had. We're also, it's worth mentioning, being asked to directly investigate cancers ourselves rather than do 2-week wait referrals. So that guidance has changed well. So the advice around doing CTs and chest X-rays, whether you can in your areas, of course, is a different matter. But that's what is set out in NICE.
Because I guess direct access diagnostics also have changed the pathways in terms of thinking about how we pick up early diagnoses of cancers. And for those areas where GPs are able to request urgent investigations, and actually, you mentioned there around responsibility of where the cancer diagnoses are taking place.
Yeah.
So that changes the landscape.
Absolutely. And we know in areas which, for example, don't have endoscopy available, the diagnoses of esophageal and gastric cancers is usually later.
Okay.
So there's good evidence for availability of investigations and earlier diagnosis.
So one of the questions we had was, a number of the cancers I've ended up diagnosing do not fit into the relevant NG12 criteria, and asking how common is that?
Very common.
Okay.
Something like 50% of cancer presentations will not fit your 2-week wait criteria, which is concerning. What we're seeing more and more now is rapid diagnostic clinics coming in, and that's part of the ACE program. And rapid diagnostic clinics will take into account other symptoms. A number of them are taking into account GP gut instinct as well. So sometimes we see patients and we think, this just doesn't seem right, and I'm not sure why, and it really gets your heckles up, and you want to do something about it, but you can't. You try and crowbar them into a referral pathway, but you often have to be you often have to put a little bit of extra information in that maybe you shouldn't. Whereas these RDCs, rapid diagnostic clinics, are hopefully going to help us with that. And I should think one day they will replace all 2-week wait referrals.
I guess one of the challenges around the 2-week wait, you mentioned around trying to shoehorn someone into what can often be an organ-specific referral, which means, yes, that colonoscopy, yay or nay, that shows anything, but it doesn't necessarily give you the diagnosis.
No.
Which is a challenge as a frontline GP.
And again, that's where the rapid diagnostic clinics will come in that they will give you a diagnosis. They'll hang on to the patient rather than you get a discharge saying no cause for whatever symptom found. You'll get a diagnosis.
Someone's asked around integrating the maps into System 1 and EMIS and what difference that might make to kind of spread awareness and develop further features.
Mm-hmm.
Do you have any thoughts about that?
Yeah, I considered that. My concern with that was it might become more of an intrusive tool. What I didn't want was pop-ups saying, have you thought of cancer yet? And although people might think that's a good idea, GPs are excellent at diagnosing cancer as it is, and they know most of the symptoms, and they just need a bit of support. And that, I'm a GP, I'm a full-time GP myself, and so I did these with helping me in mind, and I don't want pop-ups coming up at me saying this person might have cancer. I want something I can go to and use if I want to, because if we're happy enough that what we're doing is right, then we want to be left alone generally. Yeah.
Well, there's also that around getting pop-up fatigue.
Absolutely.
So actually, with the EMIS
you start to ignore it.
As all your targets and cough and all that sort of stuff, that actually you do switch off.
Yeah.
And think, oh no, not another thing. And I think your point around saying around our diagnostic capabilities are really good, and actually it's just for us to sense check what we're doing, or when we feel like we are struggling to work out in terms of the complexity of symptoms, an aid that we can use to do that.
That's why I'm always very careful to call it a support tool, rather than a decision tool. It's not deciding for you, it's showing you what's in the guidance. It's quite simply.
From your experience of developing the maps, are there any cancers that you think are particularly difficult to diagnose? And are there any things that GPs out there can do to alleviate these difficulties?
I suppose on one hand you could say the more difficult cancers to diagnose are the rarest ones. So for example, something like myeloma, which often presents with a bit of back pain, and back pain we know is very common. How do you diagnose that sooner? It's tough because I think, you know, to differentiate between bony pain and muscular pain can sometimes be ever so difficult. All I'd say is for someone over the age of 50 or 60, you'd have a bit more suspicion than under that. Use the maps if you think you should. But for me, I think lung cancer is the main one. I think lung cancer is the most difficult one to diagnose. It's the one that we diagnose late. It's the one associated with the poorest outcomes. So I think, you know, if you look at a stage 1 lung cancer, they've got a 70% 1-year survival. So stage 1 lung cancer, 30% are going to die in a year. And that's quite scary. And I know there's a lot of work going on around that, around screening and the like. I'd say lung cancer is the hardest, not necessarily because of the way it presents, but because of how aggressive it is.
You talked before about rapid diagnostic centres and how you see that being as one of the changes that we can see around early diagnosis of cancer going forward in the future. Are there any other changes around cancer diagnosis that you can expect to see?
I think we'll see more technology being used. I think we're already seeing a push towards safety netting. My colleague Pavan Randev has created a tool on System 1 and EMIS to help with safety netting. And I think we'll see more things like that. We need to trust NICE that the guidance they're bringing out is right. And so tools like the infographics, like the cancer maps and others that are out there, it's just, I think for a large part, it's raising awareness amongst healthcare professionals, not just GPs, practice nurses, pharmacists, etc., physios, dentists. I think awareness to them, but also, as I mentioned earlier, awareness with our patients as well is very important. So getting them to present early.
So we've got a question come in from Jana, which says GPs in Wales, Northern Ireland are also working with NG12. Are the cancer maps also available and accessible for those nations? And is Gateway C accessible? And or is there any other way GPs based in Wales and Northern Ireland might access the maps?
Yes, so Gateway C is available to Wales. What I do if I've lost the link to the cancer maps, I just Google Gateway C cancer maps, and it'll take you straight. The first result will take you straight there. So that's all you need to do, and you can access them around the world. Okay. You know, just Gateway C cancer maps.
Great. Well, that brings the webinar to a close. Thank you very much, Ben, for talking us through it. As I said, the resources and links will be provided, as well as the slides. So just to bring things to a close, it's clear that the cancer maps are really effective and they're a really popular interactive tool, as you said, for not just GPs, but actually the primary care workforce. The frequency of which GPs use them in the pilot really demonstrates the need for awareness and education around diagnosis of cancer. And actually, we know that the users felt overwhelmingly positive that their knowledge had increased as a result of using the tool. And most importantly, they felt more confident about making cancer referrals. And we talked before about how using this mind mapping approach definitely has applicability to other parts of medicine. So thanks again for joining the RCGP Bright Ideas Masterclass on cancer maps today. We will share the slides, and please do visit the RCGP Bright Ideas website for more information. Thank you and have a good rest of day.